My name is Joe Zork, and I'm a professor of pediatrics at the University of Pennsylvania and a pediatric emergency physician at the Children's Hospital of Philadelphia. I'm excited to be part of this program, which will explore an important recent research study assessing the use of nasal high-flow oxygen to treat infants with bronchiolitis. Bronchiolitis, a common lower respiratory infection typically caused by viruses, is a leading cause of infant hospitalization. Over recent years, the use of nasal high-flow oxygen, often referred to as high-flow nasal cannula in the US, has grown rapidly. Although nasal high-flow is not a new therapy and there is extensive research on its use in the neonatal intensive care unit, use for bronchiolitis in older infants in the emergency department and pediatric inpatient units has grown rapidly, with little evidence to guide practice. Over the past 2 years, several randomized trials from Australia and New Zealand have added important evidence on use of this therapy. I appreciate this opportunity to discuss the results of one of these trials, the Paris trial, which is a multi-center study carried out across 17 hospitals in Australia and New Zealand and published in the New England Journal of Medicine in March. The lead investigators for this study, Donna Franklin and Dr. Andreas Schibler, will present the study, and we will discuss practical aspects of applying these results in the clinical setting. Dr. Schibler will begin. Professor Andreas Schibler is a pediatric pulmonologist and intensive care physician at Lady Cilento Children's Hospital in Brisbane, Australia. He's worked in the field of pediatrics for over 20 years and has been involved in many pediatric intensive care and pediatric respiratory research projects with over 60 peer-reviewed publications and book chapters in the field. He has successfully established the Pediatric Critical Care Research Group, which is currently the major driving force for intensive care research within the Australian pediatric intensive care community. Professor Schibler is a member of several intensive care advisory boards, including the Queensland Statewide Intensive Care Clinical Network. The research direction of Dr. Schibler was driven by improving technologies for better monitoring of respiratory function and its impact into clinical practice, and it's translated into the largest Australian government-funded pediatric research grant. Dr. Donna Franklin is a clinical research nurse at the Lady Cilento Children's Hospital in Brisbane, Australia, and has 20-year clinical history of pediatric emergency and intensive care nursing and healthcare service management. She's played a lead role in authorship of the research paper in today's discussion of this paper, which was recently published in the New England Journal of Medicine. Dr. Schibler, if you want to start the presentation.
Thank you very much for the kind introduction and for giving us the opportunity to present some data on our trial that we've done here in Australia and New Zealand. And probably I have to acknowledge as well that many others have contributed to the work of high flow. So not only within here in Queensland, it actually takes us back to the work that Max Klein has done in Cape Town in South Africa. He, in principle, invented high flow. He used a nasopharyngeal catheter, insufflated room air through a flow meter and a humidifier, and he demonstrated within his patient cohort that constant flow improves upper airway obstruction and reduces the work of breathing. So that was in 1986, and it took a fair few years later when some data out of the US and some data from here in Australia showed that when you start using high flow in the intensive care unit in infants with bronchiolitis, it looks like that by using it, the intubation rates are dropping. So the study by McKiernan showed that using high flow does, in a logistic model, reduce the need to intubate. And the same has been shown by our group, that when we started introducing high flow in 2005 in an intensive care unit, the intubation rate started to drop, and we're currently sitting in Australia and New Zealand around the 5% mark of all infants intubated in an intensive care unit. Now, this needs to be taken a little bit with caution, because the overall trend of hospital admission has actually increased with bronchiolitis over the years. This study here from the UK showed that bronchiolitis is still on the rise, and we actually don't fully understand why we have more admissions. Is it just more healthcare provision, or is it indeed a problem that we are facing that's on the uprising trend? So that's the UK data showing that we have more hospital admissions, and we presented recently as well some data of patients admitted to the intensive care units in Australia and New Zealand over a period of 12 years. What we have shown is the healthcare resources, so these are the blue and orange bars, they are starting to increase despite that the length of stay within these intensive care units who have contributed to the data is reducing the length of stay. So the costs are going up, the length of stay is coming down overall, but it looks like that units are just admitting more patients, and there's a big question mark why. Within this registry study, we showed as well that the risk to be intubated in Australia over the 12 years period where we observed all these intensive care units is quite variable. So this slide just shows the risk to be intubated for bronchiolitis, but it's risk adjusted. That means that, you know, the risk of bronchiolitis with a comorbidity, for instance, cardiac disease or prematurity with chronic lung disease. So you can see that if you are admitted to a unit like one on the right-hand side of the graph, the likelihood to be ventilated and intubated is around 35%. Other units on the left-hand side are well below 10%, and that's risk adjusted. So the practice within the units are very variable, and even over the years adjusted. You can see that as a customer, you start asking the question, what's happening within these different healthcare settings within Australia and New Zealand? And as a customer, you start asking the questions, where would I like to go? And that led, these questions led us to do a pilot study that we published in 2013. And it was the principal question that we were asking, can we actually look after these children and infants with bronchiolitis outside intensive care? So me as an intensive care specialist, I was basically trying to find a way to avoid intensive care admission. So we started asking the question, can we care for these kids outside intensive care in a regular pediatric ward? And this study was performed basically during daylight hours. And what we have shown is that when these patients were cared on a general pediatric ward, we had quite a low admission rate to the intensive care. And by chance, we looked at the patients who were admitted in the after hours or on the weekends where there was no research nurse available. They went to the same wards and they didn't receive high flow. So we could show a big difference in ICU admissions. And this pilot work there helped us then to design the large Paris trial because we wanted to understand, can we keep these infants outside intensive care? Can we nurse these babies requiring high flow in a general pediatric ward? Now, there needed to be some more work to be done, asking the question, what is then high flow? What is the correct rate? So we've done a few physiological studies to investigate what is the right amount of high flow. Looking at this graph, this shows the in and expiration phase of a child, and there is a certain inspiratory demand of flow required. If we adjust now the high flow applied exactly to the maximal inspiratory demand of a child, the child will actually inspire whatever comes through the circuit. And if the child then eventually gets sicker with respiratory distress, you may see that the inspiratory demand all of a sudden exceeds the high flow applied, and there's some air entrained around the nasal cannulas, and so the child doesn't receive the correct oxygen fraction anymore because the child is entraining air around the nasal cannula, and potentially even increases the work of breathing because the nasal cannulas are sort of an obstruction as well, and the child has to create more work of breathing. So it's important that we adjust the high flow to the right amount. Now, the $1 million question is, how do we measure the right high flow rate? Christophe Milisi in France has quite nicely shown if you place in roughly 4 kilogram babies a nasopharyngeal pressure catheter in the nasopharynx, and he measured the inspiratory and expiratory pressures. So the upper dotted line shows the positive pressure that was generated during the expiratory phase, whereas the lower dotted line shows the pressure measured during the inspiratory phase. So you can see that between 4 and 6 liters of total flow, the pressure during the inspiratory phase started to become positive. And that means that is the flow that is being applied, that the patient doesn't entrain any air anymore around the nasal cannula. Out of this data set there, we have calculated roughly 1.6 liters per kilogram per minute is the right amount for infants with bronchiolitis. We basically defined then the expiratory phase as PEEP and the inspiratory phase as an inspiratory aid, because it is not a continuous positive airway pressure at the same level all the time. There's variable pressures during the expiratory phase and during the inspiratory phase. So high flow is not fully a CPAP, it's more a PEEP during the expiratory phase and some form of inspiratory aid during the inspiratory phase. We took then as well this a little bit further. We measured in infants with bronchiolitis in our intensive care unit the work of breathing by measuring intrathoracic pressures and using an esophagus pressure manometer. And we compared the measurements with cardiac babies. These babies, they just had a VSD repair, so simple cardiac surgery, and they had no work of breathing just before discharge. You can see when we switch off high flow or on high flow, and that's at 2 liters per kilogram per minute, you can see this on the graph here, that the work of breathing is quite nicely reduced, not only in the bronchiolitis, as well in healthy infants. This demonstrates that even normal healthy subjects do benefit from high flow. Taking this a little bit further, I took this on myself, and sorry, I took myself underwater. I applied 60 liters of high flow and could breathe there for 8 to 10 minutes without any problems. Here you can see that I match my inspiratory demand. I don't aspirate water, and I overcome as well the CPAP level of roughly 10-12 centimeters underwater, and can breathe nicely along without any problem. So taking this now to the next step, we planned a large randomized controlled trial in Australia and New Zealand, and we asked the question, can high flow used outside the intensive care unit in a regular general pediatric ward in infants with bronchiolitis reduce the requirement to escalate therapy? Another aspect that was quite important in that study was looking at safety and quality aspects of high flow use, and we are of course asked as well, is high flow reducing the length of stay in hospital? This trial was performed in 17 hospitals across Australia and New Zealand. Inclusion criteria was bronchiolitis less than 12 months of age, and of course an oxygen requirement with saturation thresholds of 92 or 94%, depending on which hospital the patient was admitted to. One-to-one allocation of the patients, and 1,400 patients were included in or needed to be included in the trial to demonstrate a 50% reduction in a failure rate based on historical controls from 16 down to 8%. And we asked the question, can escalation of therapy be reduced? And this was defined by persistent tachycardia, persistent tachypnea, hypoxemia, or when the early warnings tool got activated and escalation was needed. This is the standard flow chart of the trial. interestingly, was that of the eligible 2,000 plus infants, 1,600 underwent randomization. So there was quite a large proportion of the eligible patients enrolled, and only a small proportion missed out. So this trial really reflected the day-to-day activity within an emergency department. That's where we randomized these infants. 1,400 were included in the analysis. And for those who have read the paper, will see that roughly 700 plus were allocated to high flow and standard oxygen therapy. And now there's one issue around that trial. We had to allow, if the patients failed standard oxygen, we needed to allow in general pediatric wards that they were allowed to go and have a go at high flow. Initially, we didn't want to offer any crossover to high flow, but clinicians in the participating hospitals would have not agreed to participate in the study because they would have said, before we escalate therapy, before we transport a child to another hospital or admit to the intensive care, we want to have a trial of high flow to see if that makes a difference. And we'll talk about this later on in this webinar as well, about the problems and flaws that this crossover caused within the trial. The table 1 of the study shows quite an even distribution of the patients within the trial. Again, quite normal, expected, a lot of prematurity, RSV virus, roughly 50% of the cases, but nothing unusual there. Now, the main outcome was a question if there was an increase or there was a requirement of higher level of care, escalation of care. And as you can see, the Kaplan-Meier plot shows a significant difference between standard oxygen therapy and high flow. So favors high flow that reduces the need to escalate therapy. In this table, you can see that 167 patients in the standard therapy group failed standard oxygen, only 87 in the high flow arm. And you can see that there was not a big difference according to age. So if you look between 0 and 3 months, or 3 to 6 months, or greater than 6 months, there was not a big difference. The only quite interesting difference is that centers who had direct access to an intensive care, or centers who didn't have a direct access to intensive care, had quite a difference, or larger difference, depending where you admitted these patients to, with the failure rate. Discussion that's still ongoing. I'm not going too much into the detail what the interpretation of these results is. We certainly want to publish more on this effect as well. Now, the sobering result, of course, is that the duration hasn't been affected by high flow therapy. So they stay the same length in hospital, they stay the same length in intensive care or oxygen therapy, no matter what you use, standard therapy or high flow. One important, very important part of the study is that the adverse events within the trials are almost not to be taken serious in that sense. We had one pneumothorax in both arms, and both were conservatively treated. So there's no safety risk or no signal for safety concerns using high flow outside intensive care. Very important as well. Nursing ratio hasn't been different between standard and high flow. So there was a 1:4 nursing ratio. So they were not looked after by a higher nursing ratio compared to standard oxygen. So the simple conclusion of this trial is that 2 liters per kilogram per minute at inclusion threshold of saturation around 92% was significantly reduced if you use high flow. That was the conclusion of this trial, and the trial as well concluded that there's a good safety profile of high flow therapy within the trial. However, the length of stay within the hospital hasn't been affected by high flow treatment. So same length of stay if you are on standard oxygen compared to high flow. Overall, again, I'd like to acknowledge that this trial has been completed by a large group within a large group of collaborators within New Zealand and Australia, and as well a lot of regional sites have helped us to make this trial quite generalizable across different settings, from regional hospitals, metropolitan hospitals, and tertiary hospitals. So thank you very much to all the collaborators, and I will hand over now to Donna.
Thank you for the invitation to present at this webinar and to present to you our experience at Lady Cilento Children's Hospital and the regional centres that surround us with the introduction of high flow. Today, I'm going to talk to you about the way in which high flow has been introduced into our hospitals in our state known as Queensland. And I'll draw on our experiences thus far and how we have navigated the various challenges and hurdles with the use of high flow in the emergency department and the ward. I'll be able to speak to this from both our hospital's experience as well as the smaller regional centres that surround us. Just to give you an indication of the size of our hospital, we are a quaternary hospital with 360 beds, including a 36-bed paediatric intensive care unit. We admit over 41,000 children annually and see approximately 70,000 presentations through the emergency department each year. And we provide approximately 240,000 children with outpatient appointments. We've also got a retrieval service for the full state of Queensland. Queensland's the second largest state in Australia and spans very far and very wide. We're approximately the size of Texas 2.5 times, so very, very large. Lady Cilento Children's Hospital is part of a hub and spoke model, and we are the feed-in centre to over 10 regional centres that are within an 80-kilometre distance from us. And 90% of these centres do not have dedicated beds in ICU for children and therefore need to transfer them out. We recognised prior to the Paris 1 study commencing that there was an increase in use of high flow creeping into standard care in hospitals, both ours and other hospitals in Australia and New Zealand. This was done without any large evidence of its benefits in the paediatric ward setting or emergency department settings. We could also see a rise in high flow use in intensive care units since 2009, which indicated that high flow was being used in many hospitals, but they would only use it in the ICU environment. And this naturally has the cost component associated with it. We performed a survey in Australia asking the general paediatricians who led their paediatric departments how and if they used high flow in their wards and hospitals. And some of these hospitals have on-site ICUs and some do not, and they need to transfer their patients to the nearest tertiary centre. We found that out of the 83 general paediatric departments, 91% used high flow as part of their daily standard practice. And you can see from this graph the rising use of the high flow over the years since 2010. And the common age group is the less than 2 years. The common disease groups these hospitals used high flow for as common practice is shown here with bronchiolitis leading the way. And as you can tell in Australia, within our hospitals, having used high flow for a number of years now and feeling comfortable with it, there is still limited evidence prior to the Paris trial starting. From a user's perspective, high flow was introduced and used predominantly in the ICU setting to begin with, and everyone was getting comfortable with it and loving it. However, it put added stress and pressure on the ICU settings, as was tended to be used in these settings more than the wards. And then everyone was over high flow and the pressures it placed on ICU. The comfort factor had really settled in there. The ICU staff were very used to its ease of application. And then it was introduced into the general ward departments, and education rollout occurred for the nursing staff to look after these patients. And we subsequently saw the reduction in ICU admissions drop after this. However, at this time, there was no standardization across the centres on the use of high flow management in children and in which children we should use it on and what flows to apply, etc. And this is when Paris came into play across 17 centres. We know that in the neonatal world, they are fortunate to begin the research component from the minute that infant enters the world. And if there's a disease process in place for that infant, then it can be studied from that very minute on from their first breath. We know that in the neonatal world, they are fortunate to begin the research component from the minute the infant enters the world. And if there is a disease process in place for that infant, then it can be studied from that very minute. In children who do not have this occur, and instead we don't have this occur, and instead the children present through various pathways to us in ICU, from ED, the theatres and the wards. At this stage, the child has already progressed in their disease pattern, and this is when we begin our research. We think we need to be more like the neonatal world and draw that research back to when the child presents to hospital, meaning in the emergency department. We could then avoid the ICU admissions if we look at the progression of the disease and how it is managed much earlier on. However, we know that there are fear factors of placing children on high flow outside of ICU, and it may take a number of years for this shift in paradigm to occur. We have seen and heard of the stress an infant or child presenting to the smaller hospital has on the staff, and the panic that sets in when the child's increased work of breathing, for instance, is in place. And the very term high flow often can cause stress in these facilities, as they are not very comfortable to place a child on it. In adults, they were much more comfortable than children, and they're much more nervous with the children. And they would often just send the children to the tertiary centres for this very reason. And this has changed with the Paris trial and the increased comfort level of using high flow on smaller children. Taking your hospital from being fearful to functional in the use of high flow can take a number of years. Firstly, it's important to identify the issues. Do you have increased ICU admission rates, and is it caused by high flow bronchiolitis infants that could be cared for in the ward environment? Do you have any previous negative experience that can impede the ability to have high flow in your hospital? We have had some hospitals whereby executives have not supported the use of high flow in certain areas of the hospital, such as the short stay unit in the emergency department. Is this a factor that could happen in your institution? Who are the drivers of high flow? If it is the RTs, then do the nurses understand what their role is in observing the child? Who will be the staff members monitoring the patient and their high flow requirements? Is there sufficient education for your nursing and respiratory technicians, both in the use of the device you use and also the understanding behind high flow? In particular, understanding flow versus oxygen, which a lot of the staff take some time to understand, and understanding the importance of matching the inspiratory demand of the unwell patient to improve their progress. Understanding what a non-responder is and how to manage this is also very important. Other key factors to include in education is the weaning of the FiO2 to maintain the saturations at your hospital threshold. We have found that this is often the biggest problem, in that if it is not weaned very fast and patients sit at saturations of 98, 99, 100 for prolonged periods on oxygen when they could actually be weaned. We always wean as long as their sats are 92% or above in our hospital and the regional centres that surround us as well. Ensuring there is an agreement on what defines a non-responder and subsequent escalation of care needs to be agreed by all stakeholders. But how do you demonstrate how you can separate the responders from the non-responders? We've looked at this in the bronchiolitis cohort of 94 infants in 2014, and you can see that after 1 to 2 hours, the responders have improved their heart rate and respiratory rate. The non-responders have not changed their physiological parameters, and we teach the staff to watch and observe for 2 hours if possible to see if the child's improved and has more lung recruitment with the high flow. And if after a couple of hours there's no improvement, then this child will most likely require ICU admission. This slide is showing you the results of 64 Paris 1 patients that were high flow patients treated for their full respiratory support time on high flow in room air only. This is a paper that will be coming out soon. Observations were taken initially after 2 hours and then at 4-hour intervals thereafter. And it's evident in all these patients that they demonstrate what a responder is, with a decrease in heart rate and respiratory rate within the first couple of hours. And these infants' saturations were at all times greater than 96% in room air. When you implement high flow in your hospital, one of the most important items to have is a standardized guideline that talks to all areas of the hospital, from the emergency department to the ward and ICU. You also need to have the buy-in from all stakeholders, as you'll see patients moving from all areas with high flow being used. So everyone needs to be talking the same language to ensure less confusion and smooth transition for the patient and their family. We use high flow in all these areas, including theatres, and we retrieve our patients on high flow to the tertiary hospital. So again, it's important that this guideline is not only talking to your own hospital, but it's also relevant to the hospitals that feed in and link with yours. We have this in place across our state. Ensuring that the links with the regional centres are in place by communicating with the relevant parties. We link with the directors of paediatrics and the nurse educators, as the nurses are the staff who lead the high flow in our hospitals and are the drivers of the management with the weaning. As much as possible, we have aligned the guideline with the regional hospitals, and when retrieving infants who are already on high flow, we try for their full transfer on high flow to avoid intubation where possible. You may even find that the child does not need to go to ICU once transferred to the tertiary institution, and they can be managed on the ward on high flow still. Schibler performed a retrospective study in our hospital looking at the number of infants less than 2 years of age being transferred on high flow or mechanical ventilation. As you can see on the graph here, there's a steady increase in high flow use from 2008 when we introduced it with retrievals. We were questioned about what occurred with the infant after they arrived at the tertiary centre. Had they deteriorated and subsequently needed intubation? And the answer is no. The infants remained on high flow, and this has aided in the reduced intubation rate that we have in our institution. This brings us to the basic practicalities we have in place, both tertiary and regional centres, which have assisted in the success of high flow use in all these varying levels of hospitals. So ensuring that there is a standardised guideline that's accessible for all and easy to interpret and use, ensuring that you have buy-in from all stakeholders, including the ED, Gen Peds and ICU, including your executive, identifying a medical lead who will drive the high flow in the hospital and also be your spokesperson and liaison person with your external centres, as we have with the hub and spoke model, and have a structured educational rollout for all staff, and then identify champion nurses or RTs who are the go-to people for everyone. And monitor the documentation to ensure that weaning of oxygen does occur and that flows remain the same and are not weaned, and to work with other departments to ensure good patient flow occurs across the hospital. The most common questions that are raised with us are regarding nasogastric tubes, feeding, nebulizers, and weaning oxygen. We get asked these questions an awful lot. Should we place a nasogastric tube down or not with an infant and child on high flow? In the early stages, when we first began the studies, we said yes, as there was little evidence to show it causes harm if we do not place one down. We've since changed our mind about this as we've travelled through both the Paris 1 and the Paris 2 study. Looking at how we came to use it, nasogastric starts with the neonates being fed only by nasogastric tubes and not breastfed or bottle fed. We know that neonates and infants struggle to coordinate their suck and feed at the same time, so a nasogastric tube improves this, or removes this problem, sorry. We believe that gastric distension is a side effect of positive CPAP, and hence we use a nasogastric tube. These are all factors that have led us to using a nasogastric tube for our high flow patients. And also to note is during induction in an anaesthetic, the teaching for anaesthetist is to bag mask ventilate a patient with less than 20 centimetres of water peak pressure to avoid gastric distension. And we know high flow delivers well below this number. Following the exposure to Paris trials and over 3,000 infants and children on the studies, we've seen no adverse incidents with our high flow patients and feeding concerns. We teach to place a nasogastric tube down for the less than 12 months of age, and this is purely as they are working so hard and it allows them to rest while they are being tube fed. They are either continuous or bolus fed, it's up to the clinician, and as soon as the patient is improving, the nasogastric tube remains in situ for venting of any air, but the patient can begin breastfeeding or bottle feeding. However, at this time, we asked the nursing staff to turn the flows down to low flow humidified air at 2 litres per minute at 95% whilst the infant is being fed. We are still unsure of any microaspirations which may occur if the high flow is going at the same time. They can feed for up to 20 minutes at this point and then return to their previous settings. However, this is difficult to police as nurses, and we do the best we can, but we've seen no adverse incidents to date. And for the children that are less than 2 years of age, we encourage the use of the nasogastric tube. But we've noted that there's only a handful of patients we've had in our Paris 2 study, which is the age group of 1 to 4, that it's been placed in the very early days, and it rarely occurs now. And the only time we tend to use it is for hydration purposes. And these older children, they're able to sit up, belch, and remove the air from their stomachs easily. So we ask the staff just to observe for any gastric distension. With nebulizers, we administer bronchodilators. We teach the staff to remove the high flow when they administer bronchodilators. This enables a greater seal for the MDIs and also ensures that the medicine is getting down to the lungs. If it's applied with the high flow in place, the medicine will just spin around in the back of the pharynx and not be able to be any benefit to the child. With weaning of oxygen fraction, is one of the weakest components to the management with high flow we've found. It's an item that we must be repeated to the team immediately caring for the patient to ensure that they stay on top of the weaning. We teach the nursing staff about oxygen toxicity and that they can wean at any time, and this may be at a 5-minute interval, or it can be whenever they're near the patient or when they're taking their vital signs. And this can be done very frequently whilst monitoring the saturations, ensuring they're above the hospital's normal threshold. There are some hospitals in Australia that have specified time slots for when to wean and how much, and it's a very detailed plan for weaning. This is a study in the making for the future to put into place a strong weaning plan that's easy to follow and adhere to. And I'd like to thank the many nurses and doctors and funding bodies that have helped make our high flow studies a success. There's been a great deal of input into this study. Thank you.
Thank you, Donna, for this very practical approach, how we use the high flow in the Paris trial. Now, the results of the Paris trial have created a lot of discussions, and as authors, you get a lot of questions, and how do we really think the study went, and how should we read the numbers. Now, that's the part of this presentation that we as author have as well a second look at our own data. So the data that has been presented in the publication is, of course, a very sober, very straightforward look at the data and methodologically completely correct. But the reader sometimes has a different opinion, and I'm helping you to go through this, having a different opinion around the outcome as well. So as I mentioned before, one of the big issues or design problems was that we allowed a crossover to high flow, despite the crossover happened after the primary outcome occurred. But this created a lot of discussion before and of course after the completion of the trial as well, because the results can then be read in a very different way. So let's look at again the so-called purist approach of the trial. We have 1,400 patients randomized, 700 in high flow or standard oxygen, and 23% failed in standard oxygen according to our clear criteria, and only 12% failed on high flow. Or in other numbers, 88% were a success on high flow and 77% were a success on standard oxygen. So that means, 3/4 of the patients do actually well with standard oxygen and are absolutely fine. Now, as you can see, the primary outcome occurred whilst the patient was still in the general pediatric ward. And then there was the requirement to escalate therapy. And now in the standard oxygen group, they all crossed over to high flow. And in the high flow, there was nothing to cross over. And so they had nothing to offer, and they automatically went to the intensive care unit, which meant that 87 of these patients had no other option than to go to the intensive care. Now, offering a crossover in one group, but no crossover in the other group is methodologically not correct, and that's why the so-called second treatment allocation wasn't discussed in our in our study, because that wasn't part of our question. Our question was, should we or should we not use high flow in a general ward? yes or no. And if there's a failure of treatment occurring, then that's when the primary outcome occurred. And be reminded, at the time when the study was conceptualized, the big question was, should we use high flow outside ICU, yes or no? And because of that creep-in effect, because of we had to allow a crossover, the follow-on effect after the crossover within our study created a lot of discussion. So this slide here clearly shows that the study concept showed, yes, a reduction in escalation. However, when infants were then crossed over to high flow from standard oxygen, and again, 61% of these patients were successfully treated on the ward with high flow, and 39% failed. So we had, when we started high flow as a rescue therapy in standard oxygen arm, we had a much higher failure rate of 39% than afterwards going to ICU. Now, this comparison is of course not completely correct, because at that point when the rescue high flow was applied, obviously these infants were sicker than when we applied early high flow in the high flow arm. So the data here presented starts us to wonder, should we not repeat a similar trial again and say we start using early high flow versus standard oxygen, but then allow a rescue oxygen therapy. Well, this is certainly one way to go. And we presented then as well in a letter to the editor some response to these questions about early versus late start of high flow or early versus rescue. Some comments then came that a lot of countries, like here on the left-hand side in the Netherlands, they observed an increased PICU admission over the years. And as you can see, in 2016, they are at 450 in intensive care admissions. And the authors of this letter said, oh, look, high flow probably just increases the number of intensive care admission, but doesn't do anything overall. Now, on the right-hand side, again in the same letter presented, we show how in Australia and New Zealand, the Paris trial has already impacted on intensive care admission overall. The Paris trial was running between 2014 and 17. And as you can see that the Paris trial in its own has already started to reduce the intensive care admission in Australia and New Zealand. So it's not necessarily only the standard versus high flow, it is the fact that we can start using high flow outside the intensive care has basically counteracted that problem that we saw with these increasing intensive care admissions, that everyone was saying, should we or should we not use high flow and should we use it outside intensive care? This slide here, I must show that is very important, because this slide is showing a recently published morbidity of infants with bronchiolitis after having been admitted to intensive care. In intensive care, we use bad drugs for the brain. We use midazolam, we use morphine, we use other sedatives for keeping children cooperative for non-invasive ventilation or being intubated. In this trial, they showed that children who have received mechanical ventilation for bronchiolitis do significantly demonstrate long-term neurological and functional morbidity after intensive care. And these were formerly normal children, healthy, normal children. So we need to do whatever we can to avoid ICU admission of these children, because as I showed before, the practice of using invasive mechanical ventilation is very variable amongst the intensive care unit. And if we can avoid intensive care and if we can avoid mechanical ventilation, that's the way to go. So my conclusion, or our author's conclusion, is never do a trial where you allow a crossover. The reality, if you're going to do it, it is very difficult to really define a good crossover study. We suggest that we need to do an early versus rescue high flow trial to compare the early or the late use of high flow. However, we have again the difficulty to define failure when to rescue in a standard oxygen therapy arm. So that's as well from a methodology point quite tricky. But our results suggest that such a early versus rescue high flow trial has probably its merit, and someone needs to do this trial. Our trial as well showed that we probably could do better in the weaning process, where we could have improved some of the length of stay of some of these infants. We are about now to submit papers on healthcare costs. Obviously, as you can imagine, length of stay hasn't changed, so it's unlikely that we're going to save money by offering high flow outside intensive care units. So again, thank you very much for sharing with me these authors' conclusions of the Paris trial.
Thank you, Andreas and Donna. So here in the United States, just to reflect on a few issues, and I think this trial provides really a great model for us. In the US, I think one clear issue is the wide variation in care. At the Children's Hospital of Philadelphia, where I work, we did some benchmarking in trying to design our own protocol and observed wide variation in how high flow is used across US hospitals, with maximum flows ranging from 8 liters to 15 liters per minute, and very different approaches to what was allowed on the inpatient floor, whether it's not allowed at all, or whether it's used fairly aggressively. The other theme, I think, in the US, a major concern is one of charges and costs. Since this is a new therapy, often there can be high charges associated with it. At our benchmarking, we heard as high as $1,000 a day for the cost of very frequent respiratory therapy assessments. And that could be a concern, particularly since none of the evidence seems to show that high flow treatment changes the overall length of stay in a hospital or the overall, big picture outcomes. So the some of the issues that I think people might want to ask, many clinicians here in the US are probably not as comfortable with the high flow rates that you used in your study, and I think you did a nice job of explaining the physiology behind that. But do you think that lower flow rates may be effective, and would there be any benefits of that, particularly in terms of other things like feeding, because often lower flow rates are used in US hospitals?
Taking you up on the flow rates used, you may remember Kiprotis has published in the Lancet a single center study as well here in Australia, and they enrolled around 200 infants with bronchiolitis, very similar to our patient cohort. They were a little bit less sick than our cohort, and they used 1 liter per kilogram per minute. And interestingly, they did find very similar results in failure rate, ICU admission, length of stay. Again, no effect of or no effect difference in length of stay if you use high flow compared to standard oxygen. But they used 1 liter per kilogram per minute. So the big discussion around how much flow should you use and what is safe to be used is still going around. I think what we can say is in our setting, talking Australian, New Zealand setting, using 2 liters per kilogram in the less than 12 months of age is a safe approach. That doesn't mean that some of these infants don't respond to less flow. So it may be that we are giving too much flow to some of these infants. Be reminded as well that we don't wean flows, we only wean oxygen fraction. So once they're in room air on 2 liters per kilogram per minute, we switch the high flow off. So there's no weaning process of flows. So safety profile probably okay, but I think the future will be more a patient-tailored flow rate. As soon as we get better measures of work of breathing and can actually have a feedback loop of work of breathing measurement to high flow delivered, then we may actually not discuss anymore how much flow, then we will potentially have a patient-tailored flow rate, but that's future thinking. Another aspect, Joe, that you mentioned is the costs that are associated with it, and I think the US system that high flow is a respiratory therapist initiated therapy in the general ward is very different to the settings in Australia or the UK, for instance, where nurses are driving this therapy. They initiate and adapt the therapy. So there's a very different model, and I acknowledge that the model of care drives then the costs, and so we only can report on what we had here in Australia and New Zealand. Does
Right.
that answer the question?
Yeah, I think so, yeah. You brought up the weaning, and I know in many hospitals in the US, there is a graduated weaning. It's sort of something we're used to for other respiratory therapies, but clearly in your study, you went cold turkey when the patients had improved, and I wonder what your thoughts are on choosing that, going from 2 liters per minute to nothing, and whether there is any rationale for weaning.
Very interesting question as well. Christoph Milesi has just looked at using 2 or 3 liters per kilogram per minute in the intensive care settings, because he wanted to see if giving more flow is even better. What he actually demonstrated within his trial is as soon as you go to 3 liters, people then started to wean down to 2 liters, and he had quite a significant increase in length of stay just because of the weaning. So our approach is quite often with these bronchiolitic infants, they actually within just a few hours, all of a sudden they look great, they look better. So the illness is gone. And if we then have a cumbersome weaning process at that point given, it only prolongs the length of stay, and that's why we have decided let's go reducing the FiO2 down to room air, and once they're okay, well saturated, let's just stop it, so cold turkey. And again, in these 1,400 infants, we didn't have any issues with it. So again, good safety and quality profile of it.
And
right.
With the Paris 2 study, Andreas will speak to that soon, but we've actually got a slightly different weaning in that we do just shut everything off and we don't leave the children in room air for too long like we did with the Paris 1 study. So it's slightly different, and we may find an improvement with the weaning. We're yet to see.
Right. You brought up the oxygen issue, and I think that's one thing that may be a little bit of a disconnect when people read the study. At least many clinicians, I think, use nasal high flow more for work of breathing than hypoxemia. And in your study, the requirement for enrollment was hypoxemia. I think you mentioned the Capriata study. I think hypoxemic patients were excluded from that study. And then the other issue is that the indications of what is hypoxemia in Australia and New Zealand are pretty conservative, 92 to 94%, depending on the center. Whereas in the US, the American Academy of Pediatrics guidelines suggest using 90%. So how do you think those results apply to patients who are not hypoxemic? And did you ever do any attempt to analyze in children who had mild hypoxemia, for example?
So within the trial, we have the average inclusion saturation was 88%. So they were hypoxemic, but not severely hypoxemic. We have a subgroup of patients, they were treated in room air high flow only. So these are the patients, they improved their saturations at the beginning when they got in. They were sitting as well at these 88, 89%, but they never had an increase in the oxygen fraction, and they were purely treated for the work of breathing, or in other words, the hypoxemia improved with CPAP effect, as you would expect from a physiological point of view. However, we can't answer your question within the trial. What is the role of high flow purely for the work of breathing without hypoxemia? Because we had the hypoxemia as an inclusion criteria, despite fairly conservative, but we can't answer. So that's a different trial that needs to be done. I'm just very concerned that treatment for work of breathing alone may again increase the length of stay and increase the costs as well.
Mm-hmm. I agree, and yeah, I think it's probably the issue is what is the definition of hypoxemia? So the infants that were, say, 90 to 94% in your study, that could be an interesting sub-analysis. You talked about the crossover and how methodologically, purists may have an issue with that. I think it's one of the strengths of the study, actually, because it shows a pragmatic approach in the two groups. And in fact, since it takes about 9 children to be treated in the trial to prevent one escalation of care, in weighing sort of the charges and other things too, one approach would be to essentially do what was done in the crossover part of the control arm of the trial, treat the infants with regular oxygen, and then if they deteriorate, initiate nasal high flow, and we've documented that many of them will be rescued, and actually the admission to ICU was a slightly lower trend in that group than in the nasal high flow on the start group. So what do you think about that approach, basically waiting to initiate nasal high flow until the patient has a deterioration?
I think it's a fair interpretation of the results, or reading or takeaway message. The trial certainly hasn't been powered and hasn't been designed to support and recommend that conclusion, but I would say that's one way to take the results home and implement your practice. And I think it's reasonable because a lot of children on standard oxygen are doing fine on standard oxygen. They don't need high flow. I think that's a very important point. One aspect that I think is almost more important is that this trial has demonstrated high flow is here to stay. So if you're going to use high flow early or as a rescue therapy, you still need to be capable to provide high flow in general wards. So that means you need to have the education, you need to have the training with the nurses, you need to have your processes in place. So I think that if I want to say that the main conclusion of the Paris trial is there is a role for high flow in a general pediatric ward.
I'd certainly agree with that, yeah.
Add to that, just post-Paris one, looking at our regional centres in particular, just some insight into how they've travelled forward. They're all taking different pathways and taking their own perspective from the results. So some are just staying with standard oxygen and then escalating when the need occurs. Others are starting with high flow. So they've all taken a different take-home message from it and are doing different pathways for their children.
Great, I'd certainly agree with that, and I think there's definitely a role here in the US for further research and benchmarking and publication of experience to see how rolling out nasal high flow into the general inpatient ward and the emergency department can improve outcomes. Well, thank you very much.
Thank you.